This is a contrast and CT scan of a 43 years old female patient. She is a known case of carcinoma of oral cavity. This in fact is her third CT scan. In the first CT scan, there was a mass lesion along the right posterior molar and retromolar region. This mass has eroded the adjacent superior alveolar arch. The patient was operated upon approximately 8 months ago. Partial maxillectomy was done and the temporalis muscle was replaced to fill in the gap. Now this is the third CT scan. I just want to show you the extent of the lesion because we do come across such lesions quite frequently during our routine life. But it becomes very difficult to explain these lesions so that it becomes easier for the clinician or the surgeon to comprehend the lesion. In my humble opinion, the report should be such that if one reads the report with the closed eyes, he should be able to make out the exact extent of the lesion as the reporting radiologist. So there are two ways of explaining such lesions. Number one is that we explain the mass lesion first, and number two, make out the details of the eroded bone. The second method of explanation is that we enumerate the eroded bones first and then the extent of the soft tissue mass. I prefer narrating it in a way that the soft tissue mass is explained first in such a way that there is no lag. We should not jump in explaining the lesion from anterior to posterior and from above to down. The lesion should be explained in such a way that the physician or the surgeon can comprehend the exact details of the lesion that we are looking upon. For example, in this particular case, there is a mass lesion here which has involved the posterior part of right maxillary sinus, right infratemporal fossa. It extends into the right half of the nasal cavity. The mass has infiltrated right lateral wall of nasopharynx and extends into the medial part of the nasopharynx as well. On right side, it extends posteriorly into the right parapharyngeal space. Now here the mass has involved the right temporalis muscle. In fact, it was repositioned to fill the gap in the previous surgery. Now, since there is recurrence of the mass here, there is involvement of the medial and lateral pterygoid muscles. The mass has eroded the adjacent bones, posterior wall of the right maxillary sinus, medial wall of the right maxillary sinus, and the mass extends into the right side of nasal cavity. It has almost occluded the lumen of nasal cavity in this region. Posteriorly, mass has involved the right lateral wall of the nasopharynx and extends into the right side of the nasopharynx. Now please observe that here the mass has eroded the body of pterygoid and both the pterygoid plates and infiltrated both the pterygoid muscles, medial and the lateral pterygoid muscles. The lateral pterygoid muscle should have been here somewhere to be inserted into the mandible. It has been infiltrated. There appears to be infiltration of the right temporomandibular joint as well. Now this is the component of the mass in the infratemporal fossa. The pterygomaxillary fissure and the pterygopalatine fossa should have been here in this region. Superiorly, the mass extends into the inferior oblique fissure of the eye, but there is no intraocular extension of the mass. Now I will show you her corneal scan. Now this is the corneal scan mucosal thickening is present in the anterior part of the right maxillary sinus. Please observe the eroded inferior wall. Now, since partial maxillectomy has been done, so posterior part of the right superior alveolar arch is absent. Now this is the inferior turbinate on right side. As I scroll it back, the mass has eroded right side of the hard palate here. Now this is the left side of the hard palate, this is the right side of the hard palate. The mass extends into the oral cavity here at this level. As I scroll it back, it extends posteriorly along the superior ascending ramus of the right mandible. Now this is the right temporomandibular joint. Mass has involved the middle part of the temporomandibular joint. Posteriorly, the mass has involved right side of the soft palate, right lateral wall of the oropharynx, and extends into the right parapharyngeal space. There is no involvement of right carotid vessels. Superiorly, it lies in contact with the base of the skull in the region of the right greater wing of sphenoid. There is no intracranial extension through the foramina at the base of the skull. So to me, this looks more appropriate that we describe the mass gain first and then the total extent of the bone erosions in a sequence that the surgeon comprehends the true extent of the lesion just the way we are looking upon it.